Very well. Regarding today's schedule, we would like to thank you for joining us, and we're going to begin with the second technical webinar of the initiative Better Care for Non-Communicable Diseases. I will introduce myself. I'm Jonas González Garcia, responsible of this initiative, an initiative that a very important initiative in the framework of the technical cooperation of PAHO, and its goal is to strengthen capabilities in primary care, better care for non-transmittable diseases, non-communicable diseases. And this webinar is part of a set of resources related to educational activities offered by PAHO, specifically through the virtual PAHO campus. And I'd like to invite you to explore the space in the webinar's chat. You will find this link to our virtual campus. And aside from these technical webinars, you can also access the educational itinerary. There's more than 20 courses in Spanish, English, and Portuguese, and this begins with the introductory course for the initiative. And I encourage you to explore this and continue it. And also, as part of this technical webinar, I'd also like to remind all of you that these webinars, as you can participate live as we are doing so right now, and they are recorded. And the idea is that you are able to participate live online, or you can listen to them later. So if you want to get the certification of technical webinars, you will have to have heard the 5 webinars live or at later moments during the months of that this webinars are going to be given. That's still December, and then you have to take a simple test. It's a test that assesses the levels of knowledge regarding what was discussed during the webinar, and once we have complied with these requirements, you will receive the certification from the Public Health Virtual Webinar of PAHO. And without further delay, we will focus on what is bringing us here today, a second webinar that is going to explore the association of social determinants and how we can get better results through primary care. And I would like to highlight something maybe internal, but I think it's something that should be duplicated in the countries and in the teams. This is an inter-program effort. And inter-program means that we have to have the convergence of different technical outlooks to be able to advance on this agenda. And we have the pleasure of having the director of the Social and Environmental Determinants Company as Dr. David Aitman. Without further delays, welcome, doctor, and we give you the floor. Go ahead. Thank you very much, Jonas. It's a pleasure to be here with you. A very good morning to everyone. It is an honor and a pleasure to be participating in this session, Better Care for NCDs, or non-communicable diseases. Thank you for joining us in this space, and we are going to talk about a very important topic, and that is the importance how we can act over social determinants and equity in health to respond to non-communicable diseases. This space is a fruit of the interprogrammatic work, as Jonas mentioned, in PAHO, and that is why it is very important to discuss different aspects of our work so that we can provide better care in non-communicable diseases. And this space is also aligned to PAHO's mandate of promoting real health, better well-being, and reducing inequalities in health, in this case specifically related to non-communicable diseases. As we know, non-communicable diseases, I don't think I have to explain this to anyone. I think we're all here for this reason, but they represent a big burden of health expenditure in the region, and it's distributed unequitably, affecting with greater intensity the populations that find themselves in vulnerable situations. And we're going to talk more about this. In the region, we can observe specific social determinants that have a high impact on chronic diseases, such as social determinants such as unemployment, informal economies, uh, informal settlements, migratory movements, and other social matters. For example, the limitation to access to health services or labor. Precarious labor leads to cardiovascular risks, and we can continue giving examples. The evidence is clear. Without addressing social determinants and include them in what we do in our proposals and interventions, the gaps, the inequities will continue existing, and the programs will not be effective enough. So we need to have this equity outlook through social determinants so that we can get to everyone, so that we can make sure that these programs are truly programs that all of the population, independently of their economy, gender, ethnicity, can access. And for this, we need to look at living conditions and labor conditions, the income, education, gender, ethnicity, social conditions, and others, and the other underlying conditions as part of the way that we address these chronic diseases. The clinical part, of course, is necessary, especially when we talk about better care, more care for non-communicable diseases, but that is not enough. The lack of access to service, promotion of health, the results that are related to non communicable diseases are modulated by social determinants. So we need to have this equity focus in design from the beginning of the design of programs and operations of services, and this will increase the effectiveness and sustainability of our interventions. The initiative Better Care for NCDs offers us a very important framework for primary care. And we have to focus on people, we have to have active community participation, integration of social determinants in prevention, diagnosis, and follow-up, translated into concrete strategies and tools. Our Department of Social and Environmental Determinants for Health in PAHO is strengthening this interaction with concrete actions and tools that can make equity operational in the daily practices that we have in our programs. Many times we consider social determinants as actions that come from outside of a health sector, but addressing social determinants within health services, the health sector, and specific programs is critical. Some examples of this that we have worked on is first a tool that we call in English the health equity tool. And this allows us to quickly and systematically analyze health programs, including those that address chronic diseases, identifying gaps and recommendations for improvement. We are incorporating intersectorial actions. We are working on effective participation in English. We are incorporating gender and ethnicity. We are using the Social Determinants and Social Equity Initiative, and this tool will be very useful for chronic disease programs. And then, from the social determinants perspective in programs, we have elaborated for teams something for primary care. We hope this tool will be ready for the end of the year for you to use. Then we have had workshops that we have carried out and are carrying out to strengthen the capabilities of teams of primary care in different countries for the inclusion of social determinants in equity and what to do with health teams. The management guide for managing assets for health equity to complement clinical attention and to improve health results for health and for health are necessary. And we also have tools such as Innovate that you will get to know at the end of the session. And this allows us to design health programs under an equity perspective. Today, we will begin with an introduction about the relationship between social determinants and non-communicable diseases that will help us understand why it is important and how we can include this focus of social determinants in our approaches. And then we will learn from some experiences where we use social prescription to connect people to assets using the management of non-communicable diseases from a comprehensive outlook. We will also be looking at Chile's experience with the design of a cardiovascular program using the Innovate methodology to determine social determinants in planning, monitoring, and implementation, evaluation of the programs. And these experiences will show us that social determinants is not something isolated or specific. It is a different way to work. It is a different way to address chronic diseases, non-transmissible diseases, with the participation, with the territorial articulation, with effective intersectorial action. I would like to thank everyone who has made this webinar possible. I would like to thank everyone for the interprogrammatic work with the different teams of PAHO. Thank you very much, Jonas. And for this collaborative work that makes this series possible. And I'd like to thank all of you for your commitment to health and to health equity. Thank you very much, and we hope this is a very successful webinar. Thank you very much, Dr. Eggman. Like you said, it's working differently, so we have to learn from everyone. So this is the opportunity that we get from these spaces. And I'd also like to tell everyone who's joining us today that this activity is a virtual classroom and will be saved as a resource in the virtual campus. You will be able to revisit this because we will be addressing topics that may be challenging, and therefore you will have the chance to revisit it. And I invite you to share this with other colleagues so that you can advance in this new way of, in this new approach. So now to learn a little more, we have an introductory or expansion framework for the subject matter and the participation with Hugo Vasquez, the social advisor of social determinants of the health department, health and promotion department, that will describe the association between social health determinants and some other two other concrete aspects and how this can be implemented in primary care. Go ahead, Hugo. Thank you very much, Jonas, and a very good morning to everyone. I'm going to share, tell me if you can see the presentation. Thank you very much. Let me introduce myself. I'm the Regional Advisor of Social Health Determinants for PAHO, and what I would like to share with you are some ideas that I believe are important to understand. First, the relevance, and then the relationship that social determinants have with non-communicable diseases. So I would like to start the presentation with a question that I think is key, and I would like us to think about it. What determines the health and well-being of a population and a community? Some may think that health is mainly influenced by the work of public health services or some genetic or biological aspects. And if we go even beyond, we would think it's related to behaviors. And even though all of these are true and all of these factors are related to health, our science has shown us through different studies at different times how about 50% of the disease burden can be explained by underlying social conditions, such as socioeconomic factors like education, job status, income, other material conditions of the persons, and add to that the physical environment by 10%, the transportation, the housing, public spaces. All of these impact or influence the health of a population. And the 30% that is related to behaviors such as the consumption of tobacco, alcohol, physical activity, etc. And 20% of the health is the real weight of a health system on the population. If we consider that the adoption of behaviors or the health system are also influenced by economic and political and social context, then we see the importance of talking about social determinants of health and consider this focus in the management of non-communicable diseases. So what are social determinants for health? Well, the classic definition that comes from WHO says that these are the conditions under which persons are born, grow, work, live, and grow old, together with the broader set of forces and systems that give shape to these conditions. This includes economic and political systems, development agendas, and other structural aspects. You can see the image to the right says that addressing all of these underlying conditions related to the life and work of people will help us advance to healthier and fairer societies that can support people, communities, and environments that are healthy. So, to all jump into the same page and to summarize this graphically, here we have the conceptual framework of social determinants of health. This was proposed by the WHO about 15 years ago. And we can see how the different social systems are relate and how they impact health and equity in health. And amongst these, we have two big groups of social determinants. On one hand, we have structural social determinants known as the inequities in health, and these are the structuring social determinants of power in a society. This is where we see production and reproduction of inequities in health mechanisms. We can find here socioeconomic and political context, the type of governance, macroeconomic policies, social policies such as the labor market, housing, agriculture, and some other agricultural policies such as education, health, and the culture and social values. So this context influences and produces social stratification. It positions the people and the groups in different hierarchies depending on the different axes of inequity, such as social class, education, etc., that can all translate to different levels of power, influence, resources, and opportunities. And finally, these condition or determine the determinants that we call the intermediary determinants for health. And this is the living and working conditions of the people. As I said, these are set up by the structural determinants. These social intermediary determinants are impact health and health inequities. Now, the action of social determinants of health and the social systems that create these unequal distributions of power and therefore resources and opportunities can be translated into social inequalities, inequities in health, and inequities in non-communicable diseases, which is a topic that brings us here today. And one of the first studies related to this was the Whitehall studies led by Jeffrey Rose and Michael Marmot. And here I can show you the results of the first one of these studies that was published back in the 70s. This was a cohort study to assess the risk of dying due to coronary disease with workers in London, depending on social class, the hierarchies of the different groups. And as you can see, the workers were divided into those who belong to the directors, the ones that have more prestige than executives, supervisors, employees, and finally, the others here where we have the manual labor occupations. This is cleaning, drivers, people that do maintenance, etc. And here we can see how the lower the social hierarchy, the higher the risk of dying through coronary disease. So this led us to debunk that myth of the fact that heart disease belonged to people with more stress that were the directors. And we saw that the people with less social hierarchy, well, those people had 4 times greater risk of dying due to coronary disease than the higher hierarchy groups. The interesting thing about this study is that they considered the traditional risk factors that could lead to this difference. We have the traditionals like cholesterol, tobacco consumption, pressure. They explain some differences, but not the whole thing. And this unexplained part are attributed to social determinants of health by the authors. This study is a more recent study from 2017 and was published by the prestigious Lancet review. And it groups a series of data of studies to calculate premature death rates due to non-communicable diseases according to traditional risk factors, but also according to socioeconomic level. The argument of these authors is that we always consider behavioral risk factors, but not socioeconomic ones, and it's just as relevant, they say. And as you can see in the image on the right, we can see the risks according to the different risk factors, including socioeconomic status, for the different premature death causes for non-communicable diseases. We have cardiovascular, cancer, and others. We can see how a low socioeconomic status can increase premature mortality in the different categories. And this was similar to other more classical risk factors such as obesity and alcohol consumption. And the interesting thing is that this risk is independent of these other factors down here because the models adjust, and we are seeing the independent effect of the socioeconomic status. Now, we know that we have these inequities. We know that socioeconomic status and material aspects and living and working conditions of people influence non-communicable diseases. Now, what are the mechanisms that could explain this relationship? And to respect time, because we don't have that much time, I'm going to simplify and I'm going to pause on 2 key mechanisms and how social determinants affect non-communicable diseases. First, we have the influence on other classical factors such as tobacco or alcohol consumption, and the ones that are more direct, such as physical mechanisms such as chronic inflammation or chronic stress. Of course, there's other mechanisms related to exposure to environmental agents, heavy metals or other chemicals related to cancer, pollution, other types of exposures that are connected to non-communicable diseases where this exposure is generally affecting the population in an equitable way, generally affecting those who are in a social disadvantage. But I'd like to focus on the first two ones. So let's begin with behavioral risk factors, and social determinants are related to these. So I would like to give you an example. Let's think about healthy nutrition. A healthy diet. This is a recognized factor in health, and even though habitually this aspect, or we recommend good nutrition, a good diet. We always recommend this in primary care, and this is considered an individual decision, but it's also determined socially in the most part. In fact, in this study that was carried out in Baltimore, they wanted to analyze the relationship that existed between the availability of food stores that have high nutritional value foods, and these are the ones that are the circles, the bigger circles, and the racial and socioeconomic composition of the neighborhood. So the darker the gray, the higher the socioeconomic status. So you could see that the stores were mostly in those neighborhoods, and in some of the lower socioeconomic position, they did not have these healthy food stores. And I would like to say that having a healthy diet is not just an individual choice. It does depend on a series of underlying social factors. All of these aspects related to the neighborhood, the social environment, the material environment of people has also been studied by other authors that study other related factors such as physical activities. One of the people who has most studied the connection between neighborhood and health is Ana Diaz, and she published this paper in 2010, and she was talking about the importance of the physical environment, the neighborhood, and the social environment were connected to the development of cardiovascular diseases. As you can see here, we can see how aspects in the physical environment, such as access to recreational resources, the type of transportation, the quality of public spaces, the land use, and others, influences the possibilities that the people have to carry out physical activities, which is another individual factor that is associated to known behaviors. And this, of course, in turn is related to proximal biological risks such as obesity and others that, of course, are tightly related to non-communicable diseases. So, if we consider this consideration of how social systems are influencing the adoption, and this goes to non-communicable diseases, we also have to think of communicable determinants, just like the document says. And here you have this. This is the first draft of the global report about commercial determinants of health.
The first global report on commercial determinants on health. The commercial determinants are the health encompass the commercial dimension of social determinants and include commercial practices that affect all sectors on the state. And this doesn't have to do with goods and services or ultra-processed foods or tobacco, alcohol. Not only that, but other practices as well. For example, marketing, lobbying, political incidents, and the positioning of the agenda, among other practices. As in the slide, all this is shaped by the power distribution, and they are part of social systems. If you're interested in these commercial determinants that had a lot of emphasis, in 2023, there has been a publication in the Lancet where these topics are emphasized. There are systems, channels, how these commercial factors are affecting equity and health. when we have this powerful commercial factors such as tobacco industry, food industry, and all these roles that in the systems when adopting behaviors on health, we ask ourselves if these decisions are 100% free. Consumption of tobacco or eating healthy or not eating healthy, it's an individual decision or not. And the influence of these commercial factors, unfortunately, is affecting the groups that are in a social disadvantage. All this a little bit to discuss between the social determinants and behaviors related to health, which are the most important factors when we talk about these matters. Another mechanism I wanted to comment is the effect of DSS that is not solely mediated by individual risk factors. This review here, or this image from 2022, is working or emphasizing that how the different social determinants of health, such as the kind of the neighborhood, access to education, and other services such as access to health, social cohesion, can be translated in stressors such as lack of economic resources or adequate housing, violence, food insecurity, or other adverse situations, discrimination, among other factors. All these determinants in time are going to affect chronic diseases. For example, hypothalamus, axis, and other areas in long term could cause other pathological diseases, developing non-communicable disease, such as atheroma plaques, insulin resistance, which favors the development of these diseases. And in fact, thanks to the epigenetics contributions, we have evidence that how these conditions are affecting the biology of peoples. There is a biological explanation on determinants, social determinants on health. We could say that the social and material environment, by considering this mechanism, modifies the expression of our genome, triggering physiological processes that can promote or harm health, such as, for example, as what I described in the previous slide. Low socioeconomic status is associated with earlier onset of age-related chronic diseases and reduced life expectancy. And here we have this genetic level mechanisms, such as, for example, DNA methylation, histone modification. I'm putting here some reference of one of the articles explaining this, and there is a lot of evidence studying this relation. And in that sense, when we talk about chronic inflammation, chronic stress on underlying conditions impacting and disease, we need to have all these life course, because this is happening from the beginning of life till our death. There was a publication by the clinical research, epidemiology, and prevention on the relationship between social adversity, material adversity, and the childhood adversity and cardiovascular disease towards the adulthood. All this have included 1 million people with a follow-up since 1980 to 2020 years. And they split children with low social diversity up to high diversity. In green, low adversity, and in red, high adversity. In women and men, we could see that the accumulated quantity of individuals getting more cardiovascular diseases is higher in childhood compared to the ones that didn't have any adversity. The accumulation of damage, as I said before, goes along through the course of life and is there in terms of non-communicable diseases. I just wanted to mention some examples of recent evidence on the relationship between DSS and ENTS, systematic reviews and meta-analysis that were published in recent years for all of the different diseases. Let's start with cardiovascular diseases. This study was published this year by the Cardiology magazine. There is a meta-analysis to see the relationship between uh, the social determinants and cardiovascular diseases. If you see the picture, you can see the air pollution, the noise pollution, green and blue spaces. And on the right, you can see the results that in case of to high deprivation, 24% more risk compared to the ones that have less material deprivation. And as these examples, we have these relationships to cardiovascular diseases, other DSS cancer. And in this study that is published in the Nature magazine at the end of the year last year, there was an umbrella review of socioeconomic status and cancer. And in the case of cancer, it's interesting because there are specific particularities in cancer. Mechanisms are not the same for all kinds of cancer. When there is less social status, there is less incidence, such as, for example, lung cancer, and has been supported by this study. In other cases, for example, breast cancer happens more to high social status. But what is happening a lot in these chronic non-communicable diseases is that the prognosis and the consequences depend on social aspects because they have to do with diagnosis and um, early hospitalization. People with a low social status and socioeconomic status don't have the access to treatments, or for example, breast cancer or screening for a breast cancer is less likely to or for people with less social status or socioeconomic level, and that makes it worse. In the case of respiratory diseases, this is an example of what happens to asthma and socioeconomic levels. This is a meta-analysis in 2022. They studied the different results for asthma, socioeconomic disparities in asthma healthcare utilization, and they gathered around 1 million patients, and the people with less socioeconomic level, poverty, working condition, and other factors, they systematically associated that to emergency situations, asthma, more hospitalizations, and also re re entry into hospitals. The needs of different mechanisms, such as the use of ventilators, and that means that they are more vulnerable. Now we have DSS and diabetes. This is the built environment and its association with type 2 diabetes mellitus incidence and the Social Science and Medicines magazine. And the purpose of this study was to see the connection or the relationship between the all the diabetes and social determinants. As you can see, living in neighborhoods that are exposed to an unhealthy eating is connected to um, to be prone to diabetes. As you can see in the second graph, and on the third graph, you can see that there is more incidence of diabetes. Now, in the case of walkability, the association exists, but according to this review, is not that evident. Just to end, some final reflections. One, there is abundant evidence on the effect of social determinants on the development of prognosis and non-communicable diseases. On the other hand, the mechanisms involved are mediated both by the adoption of health-related behaviors and directly through the translation of adverse social conditions into pathophysiological processes of chronic stress. Apart from that, and this is key, but I could not explain that because of the time, DSS are also closely related to the effectiveness, as the doctor mentioned before, related to the effectiveness of health programs, barriers to access and coverage, adherence to treatment and monitoring due to people's underlying social conditions. And also situations that are related to the demand from the perception of health, the kind of employment, lack of social security, or transportation issues, costs, or lack of resources to continue with different treatments and indications. If we don't consider all these barriers that are related to demand that have to do with social determinants, interventions of health will be less effective, especially in the case of people in a vulnerable situation. That's why it's important not only acting or working on an intersectoral work or structures, but also structural areas. It's important to approach to managing NCDs both outside and within the health sector, primary care. And that's the last slide I have. Yes, thank you very much for listening. Thank you, Hugo. It's impressive. And we have a lot of comments in the chat box. More than 300 people are with us from more than 15 countries. 15 countries are here, universities and foundations. Let me remind you all that this material, because there were a lot of messages, they want to access to the evidence, to the information. This is recorded. This is a training session that is going to be in the virtual campus, and you can revisit it. If you're not today with us, you can listen to this later and then get your certificate. Very good reflections, Hugo. This evidence that you're mentioning that is specific for the different pathologies, this relationship between physiological aspects to the different factors is so important. And now we're going to pass to practical experiences, and that's what we're going to see now. And we have now the important experience in Chile. Dr. Veronica Olate from the Ministry of Health of Chile in Araucanía Sur. She's going to explain the integration of the social determinants. Veronica, thank you, and I'll pass the floor to you. Good morning, everyone. Thank you for the invite. And let me share my screen. As mentioned, thank you, Dr. Albert Solar and the team to add this social determinants in the cardiovascular program in Chile through the innovate approach. The context this is developed was because of the health strategy, where the planning department, health department, along with the Reforma Commission, and supported by PAHO, called us to this initiative. And this initiative approached this analysis and the integration of social determinants in different specialties. Chile is, according to our last census, has around 18 million people, mostly women. And we don't have only a big, nice contrast of the geography, the Atacama Desert, but also a big contrast in the population. The cardiovascular node team has different people from different sectors, health mainly, health sector, and also social sector. This cardiovascular node team are from Perquenco, Chile Viejo, Araucanía Sur, and Ñuble. And the health service of Chile Viejo, Perquenco, and from the DIPRESE and DIVAP, other health entities in Chile. This is a simplified scheme of the healthcare system in Chile. Our health system is combined, public and private. 80% of the population is served by the public health, what we call it the Deputy Secretary of Public Health. Then we have this Department of Health has, as I mentioned before, two secretaries, Deputy Secretary of Public Health and the Deputy Secretary for Healthcare Networks. The Deputy Secretary for Health Network has a technical role and service provision through the health services that are related to from one of them. And we have this primary care service that is made up by municipalities, dependent service health services, and delegate services. But the big part are from the municipality services. And with this, we use this Innovate tool. It's not only a tool, but many tools that are added or that are part of this analysis strategy of health inequities and social determinants into the health programs. From August 2024, with this group of people, we started this analysis along with the ongoing follow-up of PAHO team. With this instrument, we analyzed initially how the program works, and if all the people who will get the benefit from this will get them. And this is what we did with this cardiovascular program. The cardiovascular program started in 2022 as part of the occurrence of cardiovascular events by controlling risk factors in primary care. The technical part started in 2017, and there was a supplement that had to do with the complete context where we are going to approach the program. And this was a decision of our team to define what the guidelines will be to analyze the program, because the cardiovascular program has this technical approach and different satellite approaches for diabetes, chronic kidney disease, and others. So we focused only on the technical approach and the supplement. And in this line, the program aim is to reduce cardiovascular events by controlling risk factors in primary care, as I said before. And one of the things that calls our attention is that the inequalities approach is not explicit and it's not an axis in the formulation of the program objectives. The objective or the target population is for all the people who are signed up in this service and who had any brain or cardiovascular disease, hypertension, and smokers of 55 years or more. As you can see on the screen, this is considering clinical priorities based on age, pathology, and clinical risk factors for cardiovascular disease, considering education, socioeconomic level, and other factors. The interventions on the program are mainly individual for participation, social participation cross-sector, and there is little development within the same program. The program indicators are biomedic and from the process, biomedical and process indicators, and they don't consider explicit indicators or targets for the reducing gaps in vulnerable groups. We performed this program diagram with the key stages and assumptions. Here we recognized 4 specific stages: a preventive test, and then morbidity consultations, then the access to the program, multidisciplinary management, and follow-up. One of the assumptions we have at the beginning is that the program assumes that the target population is homogeneous and would benefit most from the program. It also assumes that by making the services available to this population, people will have access to them, will use them, and will respond favorably in controlling their CV's risk factors. We also developed a theory of the cardiovascular program. Cardiovascular program theory: increased morbidity and mortality due to cardiovascular and cerebrovascular problems, barriers to accessing the cardiovascular program's health benefits, which assumes that all individuals aged 15 and older referred due to suspected cardiovascular health conditions will have access to this program, which will provide timely services associated with chronic cardiovascular disease available and relevant to their condition, aimed at controlling cardiovascular risk factors and preventing cardiovascular events. We tested if this theory was working for everyone. For this purpose, we use the available information in the Araucanía Sur Health Service, and this belongs to this area with 21 regions, and it's divided in 5 nodes. That's why we have the different colors on the screen. In 2024 census, in one of the provinces, we have 657,000 inhabitants, age 15 and over, 51% women, and there is an interesting number here. 41% belong to indigenous peoples. And the most relevant part, if we compare this to school levels of this population, there is a difference of 4 years and 2 years with the regional level. It's not a minor thing. Then we use statistic resources of the cardiovascular program. This is the summary of 2023 of the whole territory. And we related this with this other population And with the population that was recorded to work on the coverage according to the prevalence, and we realized that there were gaps in the coverage for hypertension and diabetes. We did the same with men and women in terms of hypertension and cardiovascular diseases according to the recorded data. There are differences. In the case of hypertension, it's small prevalence between men and women, and in the other case, it's high. In both cases, we realize that there is a coverage gap in the male participants. Then we also consider age in the estimated prevalence for hypertension and diabetes, and we realize that there is a coverage gap in groups of 15 and 24 years, mainly. What called our attention, and it's important to share with you, is that within the routine records, school level, housing, and other background indicators are not considered to see from different approaches the whole program. Then we reviewed the hypertension coverage and diabetes coverage in the different subregions. And we related this with multidimensional poverty percentage from 2022. And we discovered that in the subregions with higher poverty, there was more coverage and in relation to the higher coverage in terms of diabetes. And we could explain this considering the region's characteristics and in relation to these sub-regions that are more rural, which means that the FONASA population would be the biggest, meaning that the health system is working more on the territory, such as, for example, health devices and others, and private services are inexistent to supply all these health services to these subregions. We also reviewed, because of the low coverage for men between 15 to 44 years after preventive testing and screening and medical consultations. In the case of consultations, we've seen that there is a low coverage in men between 15 to 44 years old. And in the case of medical consultations by age and sex, there is a low rate in consultations in men, mainly in the same age. And we also reviewed other evidences, some of them mentioned by Dr. Vasquez, and that are important, that, for example, between 30 to 69 years old, CVD is the second leading cause of death after cancer, and 22% of deaths in men and 18.5% in women. The risk of dying from ischemic heart disease is 3 times higher in men aged 30 to 69. That the male-female ratio of hospital discharges due to cerebrovascular disease was 4:3, while for ischemic was 5:3. People with low levels of education, less than 8 years of schooling, have a 3 to 4 times higher cardiovascular risk than people in higher education. Then we also realized that economic stability increased all these diseases because of the mechanisms that Dr. Vasquez mentioned, and isolation, discrimination increased the cerebrovascular diseases.
So we checked what men between 15, what men were doing, and we could see that these men were in a economically active population, and this is the productive group that has the greatest participation. And despite this work, we saw that weighting long days, long weeks of 55 hours is associated to a greater incidence of cerebrovascular accidents, and the low literacy in health that is related or can be related to low school attendance and difficulties in accessing medical services can have negative consequences on cardiovascular health. And with all of this, we prioritized this population to redesign, and we considered men between 20 to 44. And why that age? Because in terms of gender focus, men do not have a health program that is included, even though in Chile, women's programs are related to family planning and reproductivity, but they have a program. But in men, there is no program that is focused on them. But there is a health program for teenagers that covers people till the age of 19. So the least protected population is the population of men between 20 and 44 that are economically active and low income. And why did we prioritize this group given the impact? Because we wanted to detect cardiovascular health problems early so that we can reduce premature mortality and equity, because it's still true that this group is much more vulnerable, and we see this in a context of greater vulnerability, so we have to favor access to this population and the feasibility of being able to working with them. Given that at primary care, we can establish health literacy programs and other extracurricular activities to favor health in this population. Then we analyze the barriers and facilitators for access for men at 20 to 44 and all the key stages, but we focus mainly in discovery, and we group the barriers and facilitators in 4 groups: social, cultural, economic, physical, geographic, and organizational administrative, and we related this to the levels of coverage in the Tanahashi model. For example, in the social cultural, we found that the masculinity that we have in our country makes it difficult for men to access health services because, well, they feel more masculine, and therefore they do not recognize that they may be sick and that they need help. What are the mechanisms that produce inequities in the program? We related these barriers and facilitators to intermediary social determinants, which were mentioned earlier, and we saw something similar with structural determinants. Finally, we reflected on the ways in which the mechanisms that produce inequities work, and we found vulnerabilities through this role of the provider that the men have, the low perception of risk, the low health literacy and in health, and we also thought about differential exposure. They're exposed to long work days and precarious work conditions, greater consumption of alcohol and tobacco, labor stress, and poor nutrition. And this leads to differential consequences, with less finding a bigger burden of disease and higher indirect course, and therefore men of low income or informal employment have more severe consequences and difficulty in accessing treatment. And this has negative consequence for their own cardiovascular health. We developed an inequity theory for the cardiovascular health program. So given that we were focused on a biomedical approach, we did this in a fragmented way. We worked in working hours and till 20 hours with intramural activities and activities, individual activities without any gender focus, that incorporates intersectoral approach for social participation systematically. in a context of hegemonic masculinity and socioeconomic inequalities that is driven by economic and other policies. And these lead men between 20 and 44 of low incomes face barriers in accessing general health services and specifically the cardiovascular health program. So with all of this analysis, we started to think about redesign process proposal, and the first thing that we had to do was develop this new theory for cardiovascular health to address inequities in the program. So we said that given that we have a context of in unequal social context and hegemonic masculinity, we would have a social determining focus to have a preventive promotional approach using the guidelines of the general strategy focused on the person as a model for care, prioritizing the more vulnerable groups at greater risk of having cerebrocardiovascular events, and especially men workers between 20 and 44 of low income. So we could lower the barriers in diagnosis, and we would have a perspective of gender equity and territoriality in the action. We were going to incorporate intersectorial action with key actors and social participation in all of the parts of the network with advisors from the civil society, fostering participation of unions to address living conditions that are making diagnosis difficult, generating actions meant to address social, cultural, economic, and organizational barriers contributing to increase in timely diagnosis of cerebrocardiovascular risk factors, traditional and non-traditional, and therefore reduce the mortality and morbidity from this. And this is related to a planning that we called, or the program that is called Let's Take Care of Our Health Without Barrier, Connecting Hearts and Territories. And the main goal is to lower barriers for timely diagnosis for classical and non-traditional factors in men, low-income men from 20 to 33, 43, 44, incorporating social participation in cardiovascular health to address living conditions that make it hard to diagnose and identify the disease. We have to mention this, and in our work proposal, we are proposing actions at different levels, local, subnational, and national, understanding that the team that was formed to work and to review coverage of the cardiovascular health program has people from different levels in the network. So we think that we can implement health planning strategies to optimize the supply and demand for this group and to promote cardiovascular health, not just in the territory, but also in specific places such as work sites to favor social and community participation in cardiovascular health and foster articulation intersectorially and intrasectorially. As a conclusion of the work that we carried out, the redesigning process for the cardiovascular health represents a change in paradigm, going from a biomedical focus to a more inclusive, territorial, and equitable model that recognizes the labor, social, and cultural conditions of the population in the prevention of cardiovascular problems. Thank you very much. Thank you very much for sharing Chile's experience. And this allows us to think in a new way to work and to identify in our concrete context how these different population groups are affected and how we can look at this from different perspectives. I think that's an excellent example, and it can, and I see a lot of comments on the chat. There's colleagues that are joining us. And yes, by the way, this is being recorded and you will be able to see this as many times as you like. So thank you very much, Veronica. And now we will hear from about an initiative from Canada. All of us who work in public health, uh, they have a history. Well, their history is particularly interesting, and see how this is all landed in current times, this perspective of social determinants. For this, we will have Sandra Addison from the British Columbia University in Vancouver, Canada.
Very good, thank you. So good morning, everybody. I appreciate being invited to this presentation. I'm a family physician and a public health and preventive medicine specialist from Canada. And I'm going to share some perspectives from population health and primary care regarding social connection as a determinant of health and an important protective factor for individual and community health and wellness. I'll start with an orientation to the Canadian Federation and Health System, provide a special perspective on determinants of health and a short overview of the research and initiatives, and provide links that can be shared later. So Canada is a federation of 10 provinces and 3 territories, and of the 42 million people that live here in Canada, 90% of Canadians live within 160 kilometers of the border with the US, and 82% of Canadians live in urban settings. That's just to set the context of how we deliver services in a very broad, not well populated area. Many areas are very dispersed populations. Healthcare in Canada is mostly a public funded system, organized differently in each province and paid for by taxes. Now, the federal taxes that Canada receives are returned to provinces via health and social transfers. And I've included a small table about the health and social transfers over the last 10 years. And health transfers have increased significantly, but social transfers really are stagnant over time. And these really do impact our ability to provide fair and equitable health systems across Canada. Each province focuses on different health priorities and can invest in different populations. And so we do need to understand those contexts of funding and how we can respond to the needs of people in our country. So Canada does have a small but important population of Indigenous people. Anywhere from 6 to 8% of Canadians are First Nations, Inuit, or Métis people. And in the spirit of reconciliation in Canada, many health systems are working to overcome the colonial and oppressive conditions of the health system, what we would call structural determinants of health. And in the province of British Columbia, the First Nations Health Authority is a unique organization representing the majority of of the Indigenous communities in British Columbia. And since 2013, First Nations Health Authority has been really improving our ability to respond to health needs by centering it on the First Nations perspective that's represented in this graphic. While we're learning so much about social well-being, the importance of social well-being to human health, I don't think has been explored well enough. The definition of health that's broadly, adopted and reflected in many documents, including the WHO's constitution, is that health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And in Canada, we spent much time and energy acting on physical and mental health, but for the most part, social well-being has been relatively neglected. Neglecting social wellness or well-being leads to social dis-ease. And I ask, can you improve physical and mental well-being without social well-being? I'm not sure that you can. I wonder if the degree of mental and physical disease that we are measuring in our communities could be reduced with improved social well-being, social connection, or social health, however you name it. Importantly, while individual behaviors and resilience and capacity and coping, which were mentioned in prior presentations, these can influence a person's well-being. Their social well-being is dependent on social environments and group characteristics. It's difficult, if not impossible, to create social well-being by yourself. You just can't do that alone. We're seeking to understand more about the importance of social connection in Canada at the Canadian Alliance for Social Connection and Health. The CASH is a central repository and knowledge translation hub for research and sharing information about the importance of social connection and health. People who are socially isolated experience more chronic diseases, including heart disease, as mentioned previously, more mental health concerns, including depression, earlier onset dementia, more substance use, and are generally more inactive. Canadian researchers have produced social connection guidelines for individuals and for communities. The repository of evidence on social connection is essential to securing funding and support for investment in social connection, including tools and programs to support improved social connection across Canada. One of the benefits of preparing for a presentation is finding a gem online like this brilliant toolkit from the UK called the Social Wellness Toolkit. You can really find amazing tools online, and using these tools to build individual social literacy is critical. We do need to get the word out about the importance of social connection to health. In Canada, we have another exciting initiative called GenWell, Generating Wellness Through Social Connection, by activating community leadership, educational institutions, not-for-profit sector, commerce, business, and elected officials. The team at GenWell is mobilizing Canadians toward becoming more socially connected, raising awareness of the effects of social isolation and disconnection and loneliness. GenWell is creating energy and social connection in provinces and territories across Canada. When we think about program planning and public health, we have multiple opportunities to impact the health of the population. GenWell is a universal campaign targeting everyone in Canada. Anyone and everyone can benefit from improving their social wellness and becoming more connected. For others, we consider other initiatives like social prescribing, which are more targeted and intense interventions. So what is social prescribing? Social prescribing seeks to meet the unmet non-clinical needs of many of our patients. Often patients show up in the clinical setting trying to meet their needs that are non-clinical or trying to fix health issues related to having unmet needs. Sometimes that may be inadequate income, housing, or food insecurity. For some patients, during the pandemic especially, their need was for social connection. Many frail, older adults were socially isolated, and we know that social isolation can be as bad for you as smoking or sedentary behavior. As a public health physician, I explored social prescribing as an option for my community partners to support our family physicians, provide more meaningful activities for older adults. We piloted a link worker, and our teams began working more closely with the recreation department and their programs in our communities. Slowly over time, more people with broader interests were accommodated. People became more animated and engaged with each other, naturally making new friends and laughing at get-togethers, and ultimately not needing our services any longer. Social prescribing is valuable. In the situation of an older person that may not want to leave their home, they may benefit from a social prescription or advice from their doctor saying, you need to be more socially active to improve your health. Healthcare providers are enabled through referral pathways and team-based care to make these connections and mobilize community resources towards meaningful participation for an individual. Community program can be enhanced through asset-based community development to define the services that people are looking for. In social prescribing, we use strength-based approaches to understand what interests our patients and what matters to them. And through this process, patients and communities are empowered by their health goals. So what comprises a social prescribing program or schema? And that includes a referral pathway from a healthcare professional to connect the patient to a link worker, someone who has the time to engage the patient in a discussion about a range of activities that are available to them in their community in which they can participate. In Canada, social prescribing is supported by the Canadian Institute of Social Prescribing. What do they have to say? Social prescribing works. Recent implementation research about social prescribing in Canada demonstrated positive impact on health outcomes and healthcare experiences. There was a 42% reduction in primary care appointments and up to 24% reduction in emergency department visits. There's a robust cost effectiveness evaluation, with every dollar invested in social prescribing programs in Canada earning an estimated $4.43 in healthcare savings. Social prescribing shifts the focus from the patient as a passive recipient of care to being an active agent of change for their health. Recently, the Canadian Institute of Social Prescribing has put forward two important documents that outline the work in Canada: their annual report on social prescribing projects, and the Canadian Standards Association partnered in a publication on the role of social prescribing and strengthening community health infrastructure. Social prescribing makes sense. Intervening to prevent predictable outcomes in a target population like older adults improves patient care and provider experience. It improves population health. It saves systems cost and it strengthens social growth in communities. When you have older adults who are referred to social prescribing intervention programs, we see improvements in primary care expenditures, total health-related expenditures, improved mental health, reduced likelihood of coronary disease, reducing mortality, and a reduction in rates of stroke. Social prescribing improves both health outcomes as well as system outcomes. Oops. In Canada, while every province is different and organized different, all provinces are interested in the potential for social prescribing to improve their health services. In British Columbia, the United Way and other not-for-profit organizations have taken the lead on developing social prescribing for the communities they're representing. In Alberta, the provincial government has taken a lead role, with seniors organizations taking the lead in Manitoba and Ontario, and even hospitals like St. Michael's in Toronto. Some of these hospitals, these projects are very large size policy projects, and others are small, well-defined opportunities for individuals to get these unmet social needs met, like at the St. Michael's project. Social prescribing and policy action is also fundamental to the success. Our partners at GenWell have been actively advocating for upstream investment in social connection as a protective factor for the entire population, mobilizing our partners at GenWell in government, decision makers, education, the not-for-profit sector, Indigenous communities. At the Canadian Alliance for Social Connection and Health, the Knowledge Hub for Research and Communication, they've been working hard to mobilize and encourage research and evidence development to support new investments. At the Canadian Institute of Social Prescribing, funded by the Red Cross and others, that has been pivotal to support the awareness and spread of social prescribing across Canada, supporting the best evidence and sharing networks of providers, tools to train link workers or other navigators in the system. And CISP has been advocating for the importance of collaboration, co-creation, sustainable development in the social sector programming and integration with healthcare. So back to the topic about non-communicable diseases, the determinants that are non-modifiable aside, we can look at how we can navigate some of the other determinants of health that are modifiable, like social environments, political environments, acceptance of culture and tolerance, socioeconomic factors, including income and housing, social connections, and social networks. Through influencing these determinants of health, positive experience and influences can facilitate important changes for individuals regarding their diet, their use of substances, physical activity, their ability to function and cope. On a day-to-day basis, when people feel like they fit and they belong and that they're welcome, they naturally have less stress. And as a result, we can reduce obesity, high blood pressure, high glucose, and hopefully through prevention and protective factors that we mentioned, we can ultimately prevent the development of some of the chronic diseases. When I thought about this presentation, I was thinking about causation models. One of the most contemporary models of causation at this time is the equivalence model, where simply put, outcomes are a composite of risk and protective factors for any individual. So the work that we're supporting in social prescribing in Canada really seeks to strengthen people's protective factors and alleviate some of the risk factors, thereby creating better health outcomes and preventing chronic disease and alleviating some of the pressures on the health system. So thank you so much for the time and being able to share this with you today. That's it for me.
Thank you so much, Sandra.
And now we have reached 90 minutes. I'd like to summarize after we listening to our three panelists, a final reflection. And I'll suggest you consider what you shared and also what you listened in the session today. What are your takeaways for all the different panelists as a recommendation for the people who have joined us and who will continue with this formative activity? Hugo? Thank you very much, Jonas. Okay, briefly, I'd like to mention again what I said at the beginning, how to integrate this social determinants approach and the daily activities of the health teams. These subjects or these topics look theoretical, but in practice, we can do a lot of things. considering what you mentioned and considering the other presentations, we think that these presentations are pretty good, and we can see all these services with a determinant approach in our social determinants department. We've been working on the different models, the strategies, tools to strengthen the primary care services to promote social determinants. For example, identifying barriers related to social demands, such as, for example, what the colleague in Chile mentioned, social prescription, how the community and community resources are within the health system, enhancing participation, and all this is key. And we also can progress in social services, health services. That's very important as well. And we need to progress in strengthening local governments and how from the local or regional government, we can approach this, and the NCDs in coordination with the first level services or primary care services. It's important that this is reflected in a document, and I think you should also review this operational framework so we can include all this in social determinants and what to do in primary care. We're going to explain in that document all these topics, and this will be useful for you. Thank you, Hugo. Your comment is pretty good, and this is a developing process. Veronica, if you have any message for the ones who are here with us, any comments? Yes, yes. When we look at the social determinants, we need to extend our perspectives, understanding this knowledge, and we need to think about that our health programs should not only respond to the health needs, but social health needs, approaching the disease management and also inequalities in health. Thank you very much, Veronica.
Thank you so much. I just would like to acknowledge that while we work in a health sector, the social sector and the importance of our social programming can't be overstated. We know that our communities keep people well, and our health system, treats disease. And I'd really like to see more people being kept well in community. Thank you.
And now to finish, we also have the whole team of health and social determinants team. The head of the unit is here with us. Oriel Solar, the head of the health promotion and social determinants. Before passing the floor for closing, I have also learned, and I think it's inspiring, thank you to all the colleagues for being here from the different countries, more than 15 countries here, and the different institutions. And I hope you continue spreading the word on these webinars. We will have more activities and health promotion. You have the calendar and the website. Thank you very much. And please, Oriel, the floor is yours, so you can close this webinar that is very good for all of us. Thank you, Jonas. Thank you to all the different panelists, Sandra, Veronica, and for being with us with this challenge, social determinants and the health activities. It's important to highlight these evidences that Hugo mentioned, and also some questions that I saw in the chat box. We hope that we can answer all these questions through an email. Because of the time, we couldn't answer them today. If there is so much evidence, why haven't we advanced much in terms of social determinants? And I think for that question, the challenge is how we can put all this equity or equality matters or social issues. And we see that in this specific case, it's about barriers in access, not only of services organization, but social conditions, how this impact the results, treatments, adherence. And third, there is a big gap in inequalities, and that's why we need interventions that should be coordinated with the social areas. We cannot resolve all this just in the health systems, and that's why there is a need of work on activities with communities participation, priorities, decision. And we need to emphasize that all these social determinants matters are not only, as Hugo mentioned, and Veronica and Sandra examples, are happening in the clinical area. This is something we need to consider as well. And we need to do things differently so we have different results. What we need to do is to make some changes so we can obtain different results. We'll be in contact with the different things we will be doing. As Hugo mentioned, a series of tools, instruments. Thank you very much to everyone. Thank you, Jonas. And I'll not go longer because we're closing now and I won't speak more. Thank you. You have the website for our initiative. And as Oriel was mentioning, let's continue working in this partnership towards NCDs in this new way of approaching this area. Thank you very much.